Happy Monday, everybody. I hope you all had a very Merry Christmas, a Happy Hanukkah. I think folks are celebrating Kwanzaa today, as well as Boxing Day. And today, for me, is the first day of Christmas out of the 12 days. And as promised, I'm going to give you a little synopsis of a really interesting article that I've just recently reviewed, and I will be giving you an annotated version of it and posting it on my blog site, Quantum Caring. But for right now, I'm just going to kind of give you like the down and dirty of this really awesome paper that was published in 2016 in the European Journal of Pain. Authors are Cruz, Fernandez, and Oliveira. These guys did a really thoughtful and comprehensive epidemiological review of painful procedures performed in neonates. They used a systematic review approach, and they reviewed, close to 700 articles, but as they started narrowing them down, only 18 actually met their inclusion criteria. And basically, what they were trying to analyze is understand the frequency that painful procedures were performed over the first few weeks of hospitalization, but also look and see how these painful procedures were managed, the frequency and the utilization of farm and non-farm strategies. They looked at studies in France, in Holland, in Kenya, in India, and Asia as well. And what the main takeaway is despite the incredibly high quality of research that we have available to us as neonatal clinicians related to the deleterious effects of unmanaged or undermanaged pain on the developing individual, we continue to struggle with adequate, optimal pain prevention. What they also uncovered is, although it's great if you have a guideline, it certainly does kind of set the stage for establishing a level of standardization and accountability. The presence of a guideline alone did not ensure that infants' pain during procedures was consistently managed. I just keep glancing over here at the article so I can give you as much information as possible in a succinct amount of time. For me, as an educator and a coach, and really focused on this concept of trauma-informed, age-appropriate care, it strikes me as, and I've seen it in real clinical practice, that this is a crisis, certainly for the patient. And I know that clinicians themselves struggle with these competing priorities and how to transform the experience of care for these individuals when they've been onboarded with this set of expectations and how things are done, but there's no real conscious management or measuring of the practice of pain prevention and pain management, specifically around frequently occurring procedures. This won't be a surprise to you guys. The highest number of painful procedures occur over the first 2 weeks of life, with the highest number being usually around those first 3 days, and it's across all neonatal patient populations, from preterm all the way up to term infants. They looked at infants at high risk for neurological compromise, as well as premature people with a gestational age ranging from 23 to 42 weeks in the study population that they looked at, through their review. I think we still struggle with changing our practices and changing the paradigm in which we operate on a day-to-day basis. And I think, this is really a lot of the work that I focus on when I do my coaching with the clinicians that I get to work with. We really look at what is your current practice strategy? And most folks have a very clear set of guidelines in how they should be managing pain. But where things really kind of fall apart is in the operationalization of these guidelines for practice. And so I think, from my perspective, we have an opportunity to really brainstorm around what are those redundancies and reminders in our practice environment that can help us stay on top of our game, that can help guide us to deliver that high quality of care that we want to deliver consistently and reliably to this incredibly vulnerable patient population. I think, one of the things that we can look at is our documentation requirements. I got to work with this really amazing group of clinicians down in Atlanta, Georgia, in a surgical NICU. And what we uncovered while we were trying to look at and correlate the frequency of painful procedures and non-pharm and or pharm interventions to manage the pain associated with these procedures, is that there's no place where we actually document a lot of these frequently occurring painful procedures. You basically are kind of like going backwards and saying, well, I over here in this section, I'm finding cap gas results. So I'm assuming that the patient had a heel stick, but there's no connection between that event, that procedure, and an associated management strategy or even pain prevention strategy. So I think, you know, as frontline clinicians, we can be super creative about how we design the resources that we need to use in order to optimize the care that we provide. I would love to hear your thoughts about this. I'm sure everybody struggles with this. As I said, I'm going to give you a more comprehensive annotation of this article, and I'll post it on my blog, and I'll share the link on my Facebook page. But I would love to hear your thoughts about this challenge and what are the struggles that you're having right now in your clinical practice about the consistently reliable application of pain prevention strategies in this amazing patient population that we're blessed to serve. Okay, that's it for me. Heading out downtown to hang out with the family before the holiday runs out. I hope you guys all have a great Monday, and see you tomorrow.